Hello, I'm Panitia Charantaitui. I'm the current president of the American Society of Nuclear Cardiology, and I'm very happy to join you today. So I'm joined today by um, Dr. Wael Jaber, who is the program chair of the annual meeting of the American Society of Nuclear Cardiology this year, and also Dr. Tim Bateman, co-director of the Cardiovascular Radiologic Imaging of Mid-America Heart and St. Luke's Health System and past president of the American Society of Nuclear Cardiology. So we've just had our annual meeting in Orlando, Florida, and it was a huge success. So first, Wael, let me start by congratulating you on what I honestly think is the best ASNC meeting yet. The program was so thoughtfully designed and forward-looking, and you could really feel the excitement in the hallways and the buzz among the attendees. Everyone I spoke with commented on how energized they felt. So ASNC 2025 has really truly raised the bar. And so we're going to be asking Dr. Wael Jaber to uh, take over from me here and ask really ask some questions about current practices in nuclear cardiology and how they relate to the ASNC 2025 annual meeting. Wael?
Thank you so much, Benitia, for the introduction, and thanks, Tim, for being with us, for taking the time. I know how busy you are, both of you. Really, this was a nice meeting, and again, thank you, Benitia, for supporting us as the president. Your phone calls, your push for different flavors to the program really made this very possible. Tim, you were the president of ASNC a couple of decades ago, which is wonderful because our society this year celebrated its 30th anniversary and 30th meeting. I just want to go over with you about and ask you a few questions related to ASNC 2025 and the evolution of our field. So our field has evolved over the past maybe 2, 3 decades from bringing ischemia-centric to now encompass many other entities such as infiltrative diseases with amyloid, inflammatory diseases, endocarditis. How do you think the society has played a role in catalyzing this shift? And where do you see our society maybe 5, 10 years from now, if you project that? What would a program, an ASNC 2030 look like with adopting all these in our tools to diagnose and treat patients?
Sure. Well, that's a great question, but before I actually get in that, I have to add my 2 cents to the quality of the meeting and the interest of it. Dr. Jaber, you guys, you and your colleagues and staff did a phenomenal job with this meeting. I've attended every single annual meeting of ASNC since the beginning. That's a lot of meetings. That's like 30 of them, and this one really stood out. For a whole bunch of reasons. The venue was perfect, the flow of traffic from room to room, and even for people who wanted to see a portion of one session and move to another session, it was very, very easy to do that. The other novel things that I saw was I don't know what the percentage was, but maybe 30 to 40% of the meeting had gone beyond perfusion imaging into these new realms of inflammation and infection and so forth, which was so exciting. The other novel thing I think you introduced was a deeper association with speakers from other societies, other professional societies than just ASNC people talking about CT, for example. You brought in truly CT experts, and you brought in a lot of radiologists and people from around the world to give us their perspectives. So it was a terrific meeting, and I just wanted to congratulate you as well. So looking back in history, the interesting thing about nuclear cardiology was that it really happened because the clinical community, the non-imagers, the people that were taking care of patients with coronary disease and trying to figure out who needed to have a coronary angiogram, which wasn't a simple thing back in those days in the 1970s and early 1980s. They were clamoring for something that would work for them. And nuclear cardiology had to compete, obviously, with a number of other modalities, but it did win out. And I think in the early 1970s, something like 50% of all of the literature that was making its way into the mainstream journals of the time had to do with nuclear cardiology. There was a tremendous push to meet the needs of the clinical people with advancing technology and newer tracers and newer protocols, new reporting templates, new standards of quality, that type of thing. Today's era reminds me about that because it's not like we're trying to sell our technique to the clinical community. It's the clinical community that's saying, hey, we've got some problems here, and we understand our disease processes very well, but we don't have a tool to help us with diagnosing and understanding and tracking and so forth. So it's a very exciting time for our field, and I'm thrilled that you put so much of those topics onto the program. I think in terms of what this all means for us, it's nice to have electrophysiology and infectious disease, heart failure, transplant teams, rheumatologists, all these people, telling us what they need. And we look at our current basket and, we're going to see dynamic changes in our field over the next 5 to 10 years because we obviously need new tracers. We need new focused instrumentation for many of these newer challenges that we are facing. We have to develop new protocols, new reporting templates, new standards of quality, et cetera, et cetera. So it really reminds me of the exciting times of the 1980s and early 1990s when we were focused mainly on perfusion imaging. Very exciting time.
Thank you. I think you put your fingers on something I try to replicate what we practice every day, where I'm sitting in the basement reading PET scans, for example, for sarcoid, and I'm having an electrophysiologist come and tell me about what is the inflammation, show me what it is, point it to me, do that. So with that, we got the HRS, the Heart Rhythm Society, involved in the program.
Yes.
Similarly, we have the infectious disease people walking into the room. They try to find our colleagues in radiology, but a lot of times now they read remotely. So we are the only people present in the room. So we invited the Infectious Disease of America Society, first time ever, to come to ASNC and co-chair or co-sponsor a meeting with us, a special session on endocarditis. And similarly with heart failure, you mentioned CT, you mentioned, all these other professional societies. We usually, the disease specific, ours is actually pan specific. So we can actually touch all these things. With that, I just want to go with you for amyloid specifically. We think we have too many sessions of amyloid, but I think today I met with a company that asked me, you don't have enough sessions at ASNC for amyloid. How do you see us leading this field? I told them ASNC is becoming the probably place to go to learn about amyloid, whether it's diagnosis, whether it's treatment, whether it's prognostication, whether it's what's on the horizon in terms of imaging. How do you feel us serving that specific disease now?
Yeah, well, amyloid was all over this program, as you know. I mean, I think I counted. I think I counted over 12 sessions that were dedicated to amyloid. And of course, industry also put on a number of luncheons and breakfast sessions on the topic. So it's a very hot topic, and it's got a lot of legs. It's going to, there's so many unanswered questions about it at this point in time. And By the way, the Verani lecture that Prem Soman gave on this topic was terrific. I mean,
Right.
it was just an amazing presentation. I think I think the community, the imagers that are practicing nuclear cardiology in the community uh, understand that they're kind of sitting on the tip of an iceberg here with necessity of being able to diagnose this disease accurately, to be able to track it because of the advent of new medications and so forth. Um, I think there's anxiety because uh, a lot of people don't have the right equipment at this point in time. I mean, many people have CZT cameras without attenuation correction, and it can be fairly challenging to uh, to be confident about whether you're even seeing the heart in some instances. I think there is a sense that I better design my labs carefully because there's likely going to be new tracers, and these new tracers may demand different things. Certainly, CT is going to be an important component, so there's shielding issues and so forth. I think also there is maybe a sense that if there was a reservation about getting into PET for myocardial perfusion uh, issues, I think there's kind of a growing sense that maybe this is another reason why my practice ought to incorporate PET, because it certainly looks like it's going to be potentially an important tool in addition to SPECT for AL amyloid and differentiating it from ATTR. So very exciting field of evolution.
So the question now is to Pinithya, since you heard these comments. Pinithya, I directed my late trainees in their late phase of their training to actually go to ASNC, and I asked them to go there because the hands-on sessions were, at least for me, phenomenal. The discussions, the cut to the chase, clinically important, nothing that you cannot actually take from that session and practice right away. And you have been doing this for many years. You've ran a program before, and I see ASNC as the primary place right now, even if you don't have the training at your site, to go there and actually get actual training, not just show the best images you have. We all get embarrassed during these ACE read with the ACE sessions, and we learn from each other. How do you see this evolving in terms of the annual meeting, and in terms of outside the annual meeting, what can you provide our trainees or our people, not even trainees, people who want to train? I consider myself a permanent trainee. How would you see ASNC that way?
Yeah, thanks, Wael. So I think for anyone, but for example, for early career physicians, and anyone who is in the field in nuclear cardiology, I think success will depend on two things. I think first they have to master the fundamentals of nuclear imaging, and that includes learning to look at the images, to interpret the images, to work with it. And this is now not just perfusion, but there's now flow. There are FDG PET protocols for sarcoid infection viability and amyloid potentially coming as well. And then how these tools can be kind of repurposed across a wide range of diseases. They also have to learn new tracers. So I think they have to continue to be very nimble, whether we're early career, mid-career, or late stage career, because as we enter the next phase, there are many exciting new developments, new tracers, new quantitative methods, and AI that may potentially reshape the practice. And how do we work with all of this? So I think ASNC has a role at the annual meeting to try to bring all this together for people to have not only didactic sessions, but a lot of hands-on sessions, which we did this year. You did a lot of work with hands-on, with cases with the ACEs, and also labs for people to try different programs. And I think whereas in the past, for some things, when I would get a show of hands, for example, for cardiac sarcoid imaging, there would be very few people doing it. And now, when I ask this question, the majority of the people in the audience raise their hand and say that they're doing it, and they're asking very advanced questions. And so I think it's really changed, and people are getting much more expertise in different areas. They also will have to be, thinking multimodality, how to use how nuclear fits with all the other modalities as they go forward. And they can learn this at ASNC as well. And I think the pace of everything is changing very fast right now. And that's why it's very exciting for starting a career in imaging and in nuclear cardiology as well. Outside of the meeting, I think this will be very important because there are some people who will not be able to come to the annual meeting. And then I think it's very important to stay in touch um, with the community. And we can't just meet each other once a year, but yet we can't travel, 10 times a year. So it will be very important to continue to have webinars, maybe shorter ones, and have more frequent webinars to just focus on a small, quick topic. Okay, this new tracer is coming out for PET imaging for amyloidosis or sarcoidosis, and this is what you need to know. And these are the things that you need to learn. These are the pitfalls, and just have very focused sessions, but more frequent touch points. We also need to find a way as the new advanced multimodality imaging training document comes out that, in places where some of the more advanced techniques are not available, how will people will be able to get trained in some of the more advanced techniques or some techniques that we're not using as much anymore. And so I think we will find ways to do this on an on-demand basis or webinar-based basis and try to make it really easy. This is what we try, to make it convenient and easy for people to get their education and to stay up to date.
Thank you. This is phenomenal. Like I had some questions prepared for you, but you made me now want to ask other questions, which is fine. So one of the things I noticed, I went to two sessions. One was on inflammation, and one was on chronic ischemic heart disease and revascularization. The chronic ischemic heart disease revascularization, which is still the majority of our practice, had the room filled maybe 80% full. The inflammation one was wall to wall, and people were standing in the back, and we couldn't get out of the room with the questions being asked afterwards, which is, I think 10 years ago, you would find, as you said, maybe a handful of people involved in that. And that's a tribute to all the people at the ASNC who made this, this whole thing, you have to keep trying things. And at one point, it catches up in the community. It's like wildfire right now with the imaging for inflammation and all these things. Dr. Bateman, question related, if I don't ask you this question in 2025, I'll be considered somebody from the past. AI, how is it gonna affect us? I was just reading this phenomenal article in the New Yorker about AI in medicine. This week came out this week. And the analogy he gave is having a dictionary from English to Japanese at your, disposal versus speaking fluent Japanese. Of course, you can use a dictionary and you can figure out the words, but it doesn't mean you're fluent in the language. Is this the way we're going to use AI in imaging? Is this going to be just you and I and Benithia and others have expertise in reading these images and putting a clinical context to them versus a machine reading the pixels and telling us what's normal and what's not?
Yeah, very interesting. Very, very interesting. It's the lectures that we've been getting on AI. I think, unfortunately, have not changed an awful lot over the last few years, and I think most of our constituency are clinicians. They're clinical imagers. They're not anatomic imagers. right? They think physiology and they think disease. And I think AI has a little bit of a challenge from that standpoint of taking care of patients. That's the mindset that people have. And if you're a clinical imager, you 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 think of when you look at an image, you're thinking about a patient. You're not thinking of something that's anatomic or something like that. You're trying to wed the physiology and the clinical disease process that you're addressing. Um, uh, my the part of the problem from the clinician standpoint is that um, uh, is the lack of understanding in the derivation of the different AI programs that are out there, the pros and cons of the different programs that are addressing the same clinical issue, the lack of an ability to QC most of the outputs is of concern to obviously all clinicians and clinician imagers. How to handle the outputs that don't correlate well with clinical impression. These are all issues, cost items, and so forth. The AI developers are also in competition with each other in terms of trade secrets, if you want to call it that, so that it is hard for them to get into the weeds about how their programs actually work, so that can help to build confidence for the clinical imager. And then, of course, there's the matter of cost on top of that. I think that field is going to move forward in our fields. I think it is important. We need to watch it carefully. It needs to be. There were several very excellent sessions on this meeting. I think there will need to be more. If I was going to give a word of advice, I would be saying, why don't you take little bites instead of big bites? Find little niches where AI can clearly be of benefit. Panithia has indicated some of those things at Mayo in terms of being able to explain to patients when they look in their portals, exactly what this report means, so that they don't need to make phone calls to the interpreting physician or their referring physician and have 30-minute discourses on things. But small bites, I think, is what I would like to see in future meetings. I would like to challenge that community sort of to bring practical examples of how these AI tools can have an impact.
One other thing that, and I know Panithia is going to probably shed some light on it next year when ASNC is convening an AI summit in our field. One other thing that I get asked about all the time is there's no direct, as you said, Dr. Bateman, there's no direct comparison between different AI tools. Even let's say you take something as ejection fraction, as simple as ejection fraction. And we don't have, if you try 3 different AI tools for ejection fraction, let's say for our cousins in echocardiography, you will get probably 3 different answers. And that's very important in terms of disease progression, disease regression, treatment, stopping treatment, chemotherapy, all these things. The question that I would like to address is the issue of liability. If we, let's say in a dystopian world where people start not paying attention and end up just signing off on the AI, where does the liability end? And Panithia, you're more closer to the regulatory side, your reimbursement side, but beyond money is the liability. When I am signing off on a report or when I'm interpreting a study, I am putting my expertise, my clinical impression, plus my professional signature behind that report. And when I'm doing AI, I'm just trusting a blind box so far. So where do we stand on that? Anything ASNC is doing in that terms? Because this is something actually we try to do it in the terms of the business of nuclear cardiology. Maybe we should work on it next year more and figuring out where the liability is and get some legal advice on that.
I think this is complicated, and I don't think I have answers for you here. I think this is an ongoing discussion about so many things related to, also even who owns the data when, we do AI studies. How do things get approved by the FDA? It's a very different process than other types of devices. The cost structure is also very different, and what would this look like in nuclear cardiology? It may be different from CT, for example. These are all unanswered questions.
Mm-hmm.
And I mean, I agree with everything you and Tim have said. I think we should be careful in that we should be using AI as a tool to assist us, rather than to dictate what we should be doing. It should be kind of a partner, but not a replacement. I think it can help us with, and we see that in the technical aspects. Um, for example, helping with denoising, some automated segmentation, some help with quality control in flow quantification. These are things where I think it can help with efficiency and standardizing, how we're looking at things, but I don't think it should dictate patient management and go too far beyond that. It is doing a relatively good job with some of the report interpretation for patients, where it can take information in scientific terms and translating it to terms that patients can better understand and even inject levels of empathy. So, but I think we have to be very careful that it helps us rather than takes over everything. Because I think there's a liability issue which still yet has to be defined. I think ultimately we're liable. And so I think we have to be very careful as to how we use it.
Before I thank you both for taking the time, I just want to remind everyone who's listening that what I like about this meeting, it's big, yet it's small enough to the point where it takes you back to the way medicine should be practiced, which is interactions. In an era where right now there is a lot of remote learning, remote phone calls, remote visits, this is the real deal. ASNC 2025 and ASNC programs are the real deal. People are there, they're discussing a case, they're standing up and ask you the question pointed to you, they're looking into the eyes and telling you, this is what you're saying either makes sense or doesn't make any sense, or I've seen this. It takes us back to the days when we used to, sit down, do rounds, do the debates, do the differential, do these things. So I hope that this is not something that we do once a year, that you take the lessons you learn from ASNC and do them at your center and your place. And again, I thank you for your support. Thank you, Dr. Bateman, for being an inspiration for my career. I wanted to do PET the minute I saw your first PET session, and I hope people will be inspired by people coming after us and doing things innovative at their centers. And we'll see you all at ASNC 2026 in Las Vegas. Thank you.
Great. Thank you very much.
Yeah, thanks for including me.
And thank you so much for joining us. And everybody, thank you for joining us. Thank you to Dr. Jaber and Dr. Bateman. And again, thank you and congratulations to you and your team for a great ASNC 2025. Thank you.
Thanks.